Hello, welcome to our second SoonerSelect Dental Town Hall. I'm Dr. Karen Luce, the Dental Director for the Oklahoma State Dental Medicaid Program. The Oklahoma mission statement expresses the importance of optimizing accessibility and quality healthcare and improving health outcomes for all Oklahomans. But when it comes to oral health, Oklahoma can do much better. The Oklahoma Health Report Card, which evaluated Oklahoma's oral health just a couple of years ago, rated Oklahoma a D. And still, a year later, we have not done much better. Did you know that less than 50% of all children enrolled in Oklahoma Medicaid, ages 1 to 20, have received any type of preventive care? And 66% of all third graders have experienced tooth decay. So we can do much better. And one way of improving oral health outcomes is through an alternative delivery system. It's OKA's intent to make this change to a new delivery system through collaboration with our stakeholders, such as our dental providers. And we welcome you all here today. I'm going to hand it over to Trayla Raines, our State Dental Director, who will give you a detailed rundown of our new delivery system. Thank you, Trayla.
Sure. Thanks, Dr. Luce. Trayla Raines, the State Medicaid Director at the Oklahoma Healthcare Authority. Thank you all for attending in person and virtually today. I just want to start by saying I want this just to be as much about being your meeting as it is our meeting. The purpose of this today is to get input from you, your thoughts on where we're going with the service delivery system. I want to give you as many updates as I can to let you know where we're at today and kind of where we're going, but then allow plenty of time for questions and answers and any feedback or input you may have for us. So as Dr. Luce mentioned, we did work with the governor's office and the legislature this year to pass Senate Bill 1337 and 1396, which actually requires the healthcare authority to move towards a new service delivery model utilizing third-party managed care entities. So I'll quickly go through some key provisions of what we're looking at. A lot of the slides are going to be compared to if you were around last year when we went through this process. We're going to be building off of what we went through last year, adding in some lessons learned, some extra provider protections, and refining that. So a lot of what you're going to see is going to be things that we've updated since we went through this process last year. Just to reiterate, our overall goals for this is first and foremost to improve the health outcomes for the members that we jointly serve. We're going to do that by moving towards a value-based payment and away from a payment-based system that's based purely on volume. Improve our Soonercare beneficiary satisfaction as well as our provider satisfaction. For the state, it's going to contain costs through improved care coordination of services and increase cost predictability through the use of capitated payment methodology. So what's the program going to look like? So one of the key design evolutions that we're looking at this year, it's going to be a key difference from last year, is the contracted entities that we will contract with as we go towards this model. You're going to see the term provider-led entity throughout as one of those. As you recall, last year we had mostly commercial entities like private insurance companies that we were going to work with to manage the program. This year we allow for the provider-led. So what is a provider-led entity? We're actually kind of don't know yet. We're going to find out when they send in their proposals, but what the premise is if it requires at least 51% majority ownership or governance of an organization that can still perform all the traditional back-end functions of a HMO-like entity, but it just requires an additional leverage of that provider voice in the way that they operate their business. A contracted entity could also be a traditional dental benefit manager or a traditional commercial plan. So the Senate bill actually requires that we award at least 3 statewide contracts for our dental benefit managers. The one main change here this year is that in addition to those statewide contracts, we do have the option to allow a contract to go to a provider-led entity in an urban area. Urban area is going to be defined as Oklahoma City or the Tulsa Metro and the surrounding contiguous counties. The reason for that is we know that some of our provider-led entities are going to be new to the market. They're not going to be as mature in their development as some of our maybe more commercial plans that have a nationwide, a national or a statewide infrastructure already, but we don't want that to preclude a provider-led entity from entering the market. So if they can demonstrate that they can serve an urban region, they would do so in addition to those statewide contractors, and we would require that they demonstrate the ability to go statewide within a 5-year period. So there's going to be some foundational requirements that we expect this year, much as we did last year. The things that the Oklahoma Healthcare Authority does great that we want to make sure that our new contracted entity partners do moving forward as well. Timely payment to providers. We know that Soonercare often is the lifeblood of a lot of practices in Oklahoma. The fact that we pay weekly with clean claims filed the week prior is a big deal. So we want to make sure that's baked into our requirements moving forward as well. I believe we'll have a 14-day turnaround for that. Based on our experience last year and going through our readiness reviews, most of the contracted entities last year paid even oftentimes quicker than that. We also know it's important to have timely response on our prior authorizations, and having different timely turnarounds for those authorization approvals regarding emergency services, routine service, preventive service, et cetera. We're going to have an eye on the quality metrics related to our improved health outcomes. And we're going to require that our contracted entities submit health data to the Health Information Exchange that we expect to go live sometime next year. All right, who's going to be in SoonerSelect? So there are going to be several slides here that give you a lot of details on the various populations, but long story short is everyone that the Healthcare Authority serves besides our Age Blind Disabled program will be served by SoonerSelect. So that's going to be our kids, our pregnant moms, parent caretaker relatives, our new expansion population, which as of right now has about a little over 300,000 members in it. Kids in foster care, former foster care, and children receiving adoption assistance. Those that can be voluntarily enrolled are American Indian, Alaskan Native members. They have the option to be in SoonerSelect, and that option will be up to them. It'll be an opt-in model for those populations. Excluded again is our ABDs. That includes our dually eligible members, our Medicare, Medicaid, individuals in a nursing home or an institute or an ICF IID. Those who are eligible for Soonercare by way of presumptive eligibility will not be included. Members in the BCC program or breast and cervical cancer, those being served by home and community-based services waivers. And of course, those people in the employer-sponsored insurance plan through the Healthcare Authority. Covered benefits. Again, everything Soonercare covers today for these populations will be covered by a contracted entity or a dental benefit manager. That includes our expansion adult limited benefit, our comprehensive benefit for children. They'll be required to coordinate with our contracted entities that provide the medical, behavioral, and pharmacy Medicaid benefits to make sure that our members have access to holistic care. The great thing about contracted entities and moving forward with this delivery reform is that we have the option to provide more than we provide now. There's a lot of federal regulations that don't allow the Healthcare Authority as a fee-for-service Medicaid agency to do things like pay for certain services that really impact social determinants of health. We've seen a lot of innovative examples in this space last year around ways to get folks to services, ways to do community outreach, ways to provide non-traditional services that wouldn't be covered under a Title 19 state-operated Medicaid program. This can look like a healthy rewards program and a further expansion of teledentistry, or even expansion of benefits for not only pregnant women over 21, but for our adult population that we currently have. It could be an expansion on the limited benefit we currently provide. So we would also have within the dental program, we would have dentist prescribed covered outpatient drugs would be reimbursed by the medical contracted entity that would not be responsible of our dental benefit manager. We will still have a preferred drug list that's managed by the Healthcare Authority. We also have a drug rebate program where we get dollars back from the federal government for the drugs prescribed. All those rebates will still accrue to the benefit of the healthcare authority, even though pharmacy is going through a contracted entity. Medically necessary emergency dental extractions would be reimbursed through our medical contracted entity and not the dental benefit manager. As we go through this process, we know now that our network could be a little better, especially when we talk about dentistry and specialty dentistry. And it's actually kind of a standard that we will hold our managed care or contracted entities to that's even higher than what we hold that we are able to provide today. So there will be very specific access standards around time and distance. So requiring that a dentist, for example, be within 45 miles of a member's home in an urban area. They are contracted entities will have to demonstrate that to us, not only in their request for proposal responses, but also during a very robust readiness process that the healthcare authority staff will work with these awarded contracted entities after award. As I mentioned, one of the initial slides, of course, one of the primary benchmarks of going towards this delivery system is quality and outcomes. So how are we going to ensure that we're actually getting the outcomes that we're desiring? We will have an annual independent external quality review of the quality, the timeliness, and the access of services. This will be done by an external independent organization that the healthcare authority will contract with and that has deep experience nationally in working with these type of activities. We'll have ongoing comprehensive quality assessment performance improvement programs. Consumer assessment of healthcare providers and systems surveys. That's a member survey that the healthcare authority is working on now, but it's traditional in a managed care state. As well as 3 performance improvement plans annually. Some of these can be chosen by the healthcare authority. Some will be chosen by the contracted entities themselves. And what these are is essentially, it gives flexibility to the contracted entity to say, given this area of the state, let's say we're talking about the Southeast Oklahoma, there may be very different needs for adults and children for their dental benefits, and they're on the Northwest. So this gives them an opportunity to say, I want to focus on this project this year. So then that can be one of their PIPs that year. They can implement a plan, study it, see if it worked, roll it out to the rest of the state the next year if it did. But annually, there will be 3 of those. And there could be something that the healthcare authority knows it's important to implement across the state as well. And we'll require one of those 3, for example. Also, an important inclusion this year in the RFP, as well as Senate Bill 1337, is the creation of a quality advisory committee. This will be a committee that reports to the healthcare authority and advises us on what exactly those quality measures and quality outcome requirements will be that are in the RFP and those that we will evaluate our contracted entities against moving forward. There's a wide array of providers included in this, including dentists. We're currently working with the various state provider associations to make sure that we have input from them on who they would like on this committee. Just to let you know that there will be broad input and stakeholder involvement, not only in this process, but moving forward as we, even after post-implementation. All right, finances. So of course, the main difference in moving to this model is that the relationship and the dynamic changes such that right now I know our providers are used to contracting directly with the healthcare authority. We authorize your PAs, we pay your claims, you work with our provider services. It's a direct relationship. What changes here is we will now pay a contracted entity a per member per month for all the members included in the plan, and then they will reimburse, those contracted entities that is, will reimburse the providers for services. The rates that we will pay to the dental benefit managers and contracted entities will be actuarially sound. So we've hired a consultant that's gone through all of our utilization data. They're evaluating it. They'll be approved by CMS as being appropriate. And then on the slide, it mentions a withhold agreement. What this means is, there's carrots and sticks to reimbursement, right? Or how we manage contractors. And so withhold agreement is upfront, we're telling the contracted entity, we're withholding 1% of your per member per month annual amount. When you establish that you've met certain benchmarks and proven to us that you've met our outcomes requirements, we'll start giving you those dollars back. There's also quality incentives on the back end, but we know when you withhold money on the front, and I know I'm going to get my money on the back end in addition to quality incentives, if I do better and meet that, there's a little more of an incentive. So with respect to our providers, we know that there's a general fear in the public of these dental benefit managers or contracted entities need to make an administrative profit, right? We recognize that fear. To address that, we've required that they continue to provide reasonable rates. In fact, there's going to be a 2-year window to where there's going to be a rate floor in effect. So essentially, our contracted entities cannot pay less on a fee-for-service basis than what the healthcare authority is paying the day before we implement managed care. That's for 2 years. So why 2 years? Our goal here is for our contracted entities and our providers to get to a point where they're using value-based payment methodologies that can look different per provider, per region. And we know that's not something that happens day one. You don't go into a contract negotiation as soon as they start knocking on your door, giving you a contract probably after the next 6 months or so, and exactly know what you're going to want from a value-based solution. So we want to give you time to understand those processes, to work with it and really make it work for your practice. So hence the 2-year rate floor. We also have federally prescribed payment methodologies that will continue to maintain their current existence and structure, actually per federal law. So that would be our federally qualified health centers, our rural health centers, pharmacies, Indian healthcare providers, and emergency services will remain reimbursed the way they are even after the 2-year rate floor. And I guess going back to that, there's a lot of synergy and intersection between payment rates, prior authorization turnaround, and adequate network. So we had a lot of questions last year about what if they come in and they reduce my rates by 50%? Then you're probably not going to contract with them. What we saw last year was it wasn't the case, but also we're kind of at a point where there's going to be at least 2 or 3 of these different contracted entities across the state. They're going to be vying for an adequate network. And I just mentioned how strict the adequate network requirements are. So it's really important that you keep that in mind when you negotiate with them, that it's not necessarily the fact that you have to just accept a rate sheet. This has to work for you. It has to work for them because it's important for them to maintain an adequate network. And so the rates piece is really important in that nature for them to make sure that they have you on board as a good provider. All right, what are we looking at in terms of timeline? So we will have 3 different RFPs, one of which is dental, and then we'll have what we're calling the medical, but it's inclusive of medical, behavioral health, pharmacy, non-emergency transportation, pretty much everything we provide except for dental. We'll also have a RFP that will be awarded to one contracted entity to serve our children's specialty plan. That's for all the services required for kids in the custody of child welfare services or juvenile justice services, kids in state custody. We're going to release these on little different timelines. We're expecting the dental RFP to go out in September. We expect to give probably a couple of months for response times for those bidders. And then we'll do a full scope evaluation of those using a very detailed evaluation plan. So if I would expect to see those awards probably happen in the spring. 1337 actually requires that we implement by October of 2023. So about 18 months from now. A very important caveat there is it's pending CMS approval. So there's a lot of steps we have to go through to get from A to Z. One of those important steps is CMS, our federal partners and I guess primary funders for this project, has to approve each of those steps. So we have to give them our RFP. We have to give them the awarded contract. We have to give them our actuarially set rates, and we have to go through a very robust readiness review process, and they have to see the results of that, which includes our network adequacy information. If at any point they say you're not ready on any of these, we have to press pause until we get ready. So there's a chance it could be delayed beyond October, but we're going to do everything we can to get there. All right, so I know I'm a fast talker, but I wanted to allow the majority of the time for a Q&A session. Again, I really want this to be more of y'all's meeting than our meeting. And this really is a chance to let us know if you were around last year and you went through this process, you have fears or you saw things that we could have done better, let us know. Or if you have a question, making sure that we've added in a protection that you're concerned about, let us know. Chances are in the 500-page RFP that we've developed, it's covered, but we don't want to miss that. So now's your chance. We can start with whoever's in the room. Okay. And I was just reminded, if you have joined us online, to enter those questions in the Q&A box and we will field those in the room.
Okay, Trailer, I have a couple questions for you.
Planted questions, love them.
Planted questions, we're always prepared, right? So how will this affect reimbursement for orthodontics?
So it would be the same as my general statement earlier, in that orthodontists, of course, would be covered in SoonerSelect as a covered provider. Their rates would stay the same as they are the day before that we go into SoonerSelect for those first 2 years.
How will patients be transitioned from Soonercare to managed care? Now, these are questions that were provided ahead of time. So these are the ones that were asked multiple times. So we know that these are on the minds of many.
Yes. So as we get to the point of getting through our RFP process, we've awarded them. There will be a very robust communication plan to our members. We will transition a lot of our current call center staff into enrollment agents or choice counselors. And so members can go online. They'll have access to a chart that basically describes the differences between each of our contracted entities. Like I said, the covered services are going to be across the board, but each may have different value added benefits. And so we want our members to know what those value adds are as they choose their plan. They can call member services to ask what, kind of help and assistance with choosing a plan. For any new members coming on, when they go to enroll in mysoonercare.org, instead of choosing like on the medical side of PCP, for example, there will be a drop-down box where you can choose a managed care plan to be aligned with. But there'll be very robust communication. There will not, we have like a tiered way of doing this. The very last piece in that tier is an auto assignment. And it's only if you've gone through several steps of not choosing. We'll go through a very simple round robin logic of going around each of the dental benefit managers until everyone has been assigned. The logic in there wants to maintain families together. And so, for instance, if mom is a member of a managed care plan, we're not going to separate and put kiddo at a different plan. We're going to make sure those families are kept together.
You mentioned earlier that there would be a separate contract for children under state custody.
Yes.
Will that contract also include dental, or is it for all other services other than?
Good question. So the children's specialty contract will be exclusive of dental, but there will be requirements, of course, for coordination among the plans. So they would cover all the medical, behavioral health. It's more intense around care coordination for those families and the kids in custody.
So earlier you mentioned that emergency dental services would be filed to the medical provider piece.
Yes.
So like for my providers, they're specialty providers. So jaw fractures that come through, a lot of times we file those under dental for those children. If it's flipped to the medical side, do we now have to file a CPT code and take a reduced rate?
That's a great question. As I was looking through the slide earlier, I couldn't remember if there's a difference between place of service. So like if an emergency service is provided like an ER or a non-dental office. Dr. Lewis, do you remember how we handled that last year? If not, I can phone a friend. I think Sandra's online, so maybe we'll be able to type something in our chat. But great question. We'll track that out for you.
It's another question. Is there any incentive or recruitment happening to gain more dental providers that will accept Soonercare for adults?
Yes, so I will say two things there. Currently, we're working on enhancing our healthcare authority's fee structure to pay providers higher than we currently do, to incentivize not only seeing adults, but more of our kiddos. And yes, second of all, I fully expect our contracted entities in the dental space and the medical space to make those incentives as well. There's actually an opportunity here to be reimbursed more under a third-party system like this than you do under the healthcare authority currently. I'll add to that just because it popped in my head and around protections, and it was kind of around your question about billing. I know there's also probably going to be concern about, I go to a single portal right now. I go to healthcare authorities portal and it's easy and you pay quickly. I don't want to go to multiple portals. One thing we learned last year was exactly that. So we're going to require this year that they all use a single streamlined portal with something like a drop-down box instead that, you know, figures it out on the back end. We actually recognized this last year and that multiple plans already did this together. I forget the actual name of the portal used, but it had great functionality. It's single sign-on for you, have a drop-down box. It makes it a lot easier. So I know that was an important lesson learned from last year. Similarly, around credentialing, we're identifying ways to make that a lot more streamlined and easy so that you're not doing different credentialing processes for each individual dental benefit manager you're working with.
Earlier in the introduction, you mentioned a transition to value-based payment. Is that something that will start, or will the healthcare authority start that process during the change, or is that something that comes after contracts are awarded? And
so we will not start the value-based payment process. That process will be more of a relationship between the contracted entity and the provider. Now, what we will do is have expectations and timelines around achieving that for our dental benefit managers and expect them to bring the providers along. Now we can help be of assistance to both the provider and the managed care entity at that point, but it's going to be an expectation for the entity moving forward.
Okay, Trailer, will the flat rate continue after the PHE is lifted?
If by flat rate, we mean the reimbursement rate. Yes, I'm going to go with yes. So the reimbursement rates, I think this was a question submitted. The reimbursement rates don't really have anything to do with the public health emergency. Right now, the public health emergency regarding COVID is still in effect. The major impact there is that the healthcare authority accrues an enhanced federal matching dollars for services, which is great. It also means that we can't unenroll any Soonercare members for any reason other than they move the state, they choose to disenroll, or they pass away. So right now we're carrying around a little over 200,000 individuals that no longer meet Soonercare eligibility criteria, but we cannot, by way of receiving those enhanced dollars, remove them from the program.
My first question is for a qualification for orthodontics. Will the qualification criteria for the patients remain the same, or will those change?
So in general, like medical necessity criteria, prior authorization criteria cannot be more strict than what we're doing currently. Now, and kind of what we saw last year was some easing of criteria, especially on stuff. Maybe let's say we prior authorize stuff and have a 98% approval rate. They may adjust that some and choose to PA things differently. But in general, they can be more restrictive.
And then the other question is, when will our, for example, our insurance coordinators start to see a change in their day-to-day activity where they'll be going into this different portal for processing insurance for patients? When will that effective date be when they'll see their day-to-day activity change?
So I would say not until after implementation, but I would anticipate that there's going to be some pre-work there between the contracted entity and the provider themselves. So once we have our awards and we know who our partners are going to be, we knew who they were last year, it may not be the same this year. They will aggressively start building their network and getting contracts out to you. At that point, I know they have an extensive team of provider education specialists that will begin working with your office staff about here's how you log in, here's how you get ready, so that by day one comes, they know how to do it, they're familiar with it. It's actually another great resource I think they're going to bring that maybe we don't have internally at the healthcare authority is a lot more boots on the ground in terms of practice help in your office. So to answer your question specifically, probably midsummer, I would say early summer next year is when they could start probably educating.
Trailer Sandra was able to answer the question that
she
was
would be.
asked earlier. And she says that urgent dental care will be covered through the dental coverage provided under a DBM.
Okay. So that means it would not be covered by the medical contracted entity in that circumstance.
We have a few questions online that we're going to go ahead and ask
Sure.
of you as well. Will providers be locked in for a set amount of years with the contracted plans, or will providers be able to terminate contracts whenever or as needed?
It's not, well, I think we can define as needed. There are some certain clauses within the RFP that we would allow for immediate termination of the relationship with very specific criteria. But in general, I believe it's during there's going to be a plan year that a provider can opt in and opt out.
How does value-based care relate to dental offices?
You know, it's going to be different than it would in a medical facility or a contractor relationship with a CE, but I did see some innovative ways last year, for example, around some plans proposed dental homes to where they provide kind of that partial per member per month quality-based monthly payment in addition to a fee-for-service payment. It can kind of look different per contracted entity, and it can look different per contracted entity to provider.
For oral surgery, emergency extractions are covered by medical under this plan. Currently, we file as dental.
Yeah.
Being asked quite a bit online.
Yes.
When will you be reaching out to the provider associations to get our recommendations for the Quality Advisory Committee?
We have begun having those conversations. So it's going to be ongoing probably for the next few months, but we've begun those conversations.
Will there be variations in coverage and authorizations for the DBM versus OHCA?
I think that goes back to the medical necessity question around, we will have very strict turnaround timeframes for our DBMs in terms of approvals. And in general, they cannot be more strict in terms of prior authorization criteria than we currently operate today.
Will ambulatory surgery centers be able to negotiate fees for outpatient surgeries for dental surgeries requiring general anesthesia? Currently, the reimbursement rate is so low, it is hard to get time in ASC.
I can't answer specifically, but I will say in general, yes, that is something that can be negotiated between the provider themselves and the dental benefit manager. And I will say too, like the comments and the questions being received, these will also be tracked by our team so we can make sure that we have incorporated it into the RFP and our thinking and our system design moving forward.
We don't have any other questions online.
Anything that keeps anyone up at night about this? Any major stress? Yes.
For orthodontics, do you anticipate any possible transition from a fee, or a compensation, which is currently based on time in treatment, to one that is based more on quality of the result with investment in technology and investment in more time and attention to what you're doing with each appointment with patients? Orthodontic treatment can actually be higher quality and provided in less time to the patient, but often this is not compensated. It's compensated on time right now. We feel like that could be different and it would serve patients better and help to get the value-based compensation model that patients and you guys are looking for. Is that something that you see as being something that could be negotiated or finding a way to do that?
Yeah, you actually just answered my value-based payment question. That's kind of exactly what we're trying to get towards. And you articulated it perfectly better than I could. And yes, I will say, I think we actually have some potential vendors in the room that I would expect to bid on this. I might want to have a conversation. But yeah, that's exactly where we're trying to get to, something like that. I will say too, we'll do another round of these after we do have awarded contracts. And so you can actually meet who the partners are going to be, ask these questions of them. Each of them may have different answers on how they get there. But we'll want to allow our providers that opportunity to meet and get comfortable and know to reach out to them.
Trailer, this is Sandra. Can you hear me?
I have a final question. When will you actually allow benefit managers to approach dental practices about partnering with them?
So good question. We cannot prevent a potential partner from reaching out now. And just kind of FYI providers, what you'll probably start seeing if you haven't already is some reaching out, asking for letters of intent to contract, because they will, in preparing their bids, start needing to demonstrate for their response that they have an adequate network. And so along with that, they want to be able to say, we have 300 letters of intent from providers across the state, and they've agreed to turn this into a contract if we win the award. So I already know that's going on now. So I've heard it from the community. There's nothing wrong with that. And technically nothing we can do to control that. Now, what I would advise for the providers is make sure you know what you're signing. We saw a lot of different variations of these documents last year. Some had clauses that automatically convert the letter of intent to a contract upon award. So it's important that if that's important to you to know that, pay close attention, work with your associations maybe. After we've awarded those contracts, we would expect for them to then start soliciting even harder for actual contracts. It's that level, it's at that point that we will have more control, because at that point they're a contractor, but we would expect them to do what they need to, of course, get an adequate network. All right, anything else? Yes, sir. I really wish we could just be at a table together. Like, it feels so weird in this audience.
Regarding the three companies competing for network members, how often do those companies compete and come to the table? And how long are they awarded as being one of the three that get the contract with the state, or
Like
if I'm articulating that properly? Yeah, kind of how often do they compete? What three companies are they? Do we know, or is there a ton of companies right now that are competing to be one of the three? How's it working?
Yeah, so we just know how many we're going to award, and we know who was in the business last year that bid and were awarded. There could be some more this year. What we're allowing for this time is the opportunity for a provider-led entity that maybe wasn't around last year that got together since 1337 was created. Once awarded, though, they're awarded on, I want to say 5-year terms. And so they will have a contract for those 5 years. Now, there could be a time when one says, you know what, this isn't financially working for me, I want out. And so at that point, we would open it up to bid for the one that left. There could be a time where they're not meeting our standards, and we've gone through all of our remedies and ended on the final one, which is termination of a contract. So either exit at their choice or ours would be an opportunity to open it up for a new bidder in the space.
Kind of following that, how many of those that are competing will be dental versus how many will be medical? Because I know last year there was 3 or 4 medical and 2 or 3 dental. But if we're talking about 3, is that 3 dental, or is that 3 medical, or 3 combined?
Each, not combined. Okay. So we would expect to see 3 dental, at least 3 medical, and then the children's specialty. There'll be 1 of those. So it's all together. Anything else online coming through? Melissa.
I have a few more questions for you online. Okay. Will different plans cover certain areas of the state, or will there be cross coverage in areas by multiple plans?
Yes, so we would expect 3 to be statewide, can cover the entire state. The only time we would allow an urban contract is if we have a provider-led entity, and then they would operate in that urban area in addition to the 3 statewides. Now, I think the part I failed to mention earlier too is that there will be preferential scoring for a provider-led entity. It doesn't mean they get a pass on all the basic requirements. They would still have to be licensed by the insurance department, have reserve requirements and all the things that a commercial insurance company would. But by being a provider-led entity, they would have preferential scoring moving forward. I will say so far, we've not been approached by any provider-led entities in the dental space. So if they're out there, they haven't approached us to chat yet. All right. Well, no use in keeping everyone if there's no more questions. I think I've covered everything I can. But stay on the lookout. We'll update our website. We'll create a webpage specifically to SoonerSelect. Like I said, the next thing you'll probably see is when we release the RFPs at some point in September, and then awards probably December, January. But in the meantime, feel free to reach out. Thanks for attending.